Good evening, everybody, and welcome to our SiteCare webinar this evening. We had, I think we've got about 120 or so registrants, so hopefully the majority of them will be joining us this evening. So I'll just wait a couple of seconds just to let everybody get logged in. The numbers are increasing as I speak. While people are just connecting with us, it gives me great pleasure to introduce Mark Chatham, who's our very experienced presenter this evening. Mark, I'm sure you all know Mark from his time when he was working at CooperVision, or probably are working with them currently. But as you know, Mark is a contact lens practitioner and an educator from Cheltenham, and he's been specialising in contact lenses since way back since 1997. He owns his own mainstream practice and his own specialist consultancy managing the needs of the complex contact lens patients. So I'm sure you've all come across Mark over the years. Mark's also been very active in the sort of regulatory and support of opticians, whether that be in the GOC, his professional services roles at CooperVision, as I said, and he's also an associate tutor at Cardiff School of Optometry and Visual Science. So we couldn't have a better speaker this evening to be talking to us all about how can managing dry eye help retain your contact lens patients. Just before I hand over to Mark, you'll see at the bottom of your screen there's a question and answer icon. If you've got any questions you'd like to ask, please pop them into the Q&A icon section, and Mark will be aware of those as they come in. He'll probably look to answer them at the end of the webinar. But if anything comes up that's pertinent, he'd like to be aware of it at the time, and he'll bring it into his discussion. There's also a chat function. Please use that to chat amongst each other. Mark, again, if there's anything comes up in that he thinks is relevant to comment on, he'll pick that up as well. And of course, at the end of the presentation, we'll have a question and answer session ready. Also, everybody's aware that this is a CET webinar, so hopefully we'll be able to get you all to return the feedback form, which we'll send out to all the attendees tomorrow. So look out for that, and please get that back to us as soon as possible, and we can get the CET points arranged. Right, without further ado, it gives me great pleasure to hand you over to Mark, and I hope you enjoy this evening's webinar. Thank you, Mark.
Well, thank you very much, John, and good evening to everybody. I'd like to start off by taking a little bit of time to thank you for attending this evening's lecture, which is how managing dry eye can help to retain your contact lens patients. And I'm very grateful to John and the SiteCare team, and also to Gary Daniels from Avisor for helping to facilitate this webinar this evening. Now, this slide now is redundant. I was just going to introduce myself and tell you who I am. I'm an independent contact lens practitioner and educator, has already been said. Just one minor correction from John's introduction is that I don't currently have my own practice. John's already run through my disclosures, but so I'm an associate tutor at Cardiff University. I do some work with the Hakim Group as well, and of course just like to reference Avisor as well, who I do produce educational materials for. When I was looking for a picture to add a little bit of colour to this slide, I decided not to go with the usual head and shoulders shot, but to try and find a picture that sort of sums up all the things that I like to do, just to give you sort of some idea about myself and what motivates me as a practitioner. This is a picture of me with three very dear friends and colleagues from Cardiff University, Dorian, Pete and Andrew, and this is us in Malawi last year, where the guys visit every year and run some amazing remote refraction clinics. And I was very honoured to be invited to join them in Malawi to go and run some educational keratoconic workshops with some local ophthalmologists and optometrists, and we actually set up the first keratoconic contact lens clinic in Blantyre, Malawi. So I should be there again this year. That's not going to happen, but if I keep an eye on this picture, hopefully it will remind me that next year we might be back to something like normality, and we'll be able to go back and finish off the work that we started last year. So there's a little bit about me there. Here's our agenda for this evening. I'm going to take you through the CET requirements. And then we've got three main headings here: patient retention, contact lens associated dry eye. You'll probably hear me refer to that as contact lens related dry eye as well. Contact lens related dry eye management, and then we're going to have the Q&A session at the end, which John has already mentioned. So something that is I'd like to point out at this stage, which I think is very important, that the scheduling for this lecture and the work that was done to kick off this project, that commenced late last year. So this is way before COVID-19 was something that we'd even heard of. And I want to draw your attention to this little red dot up here, because we had a little conversation with John and myself last week, and we felt what would be very important was to make this, make the lecture as relevant as possible to the conditions under which we're practicing now. And they're very different to normal. So wherever we have a red dot, I'm slightly changing the emphasis of the slide from its original intended content. And we've had to do that very professionally. We had to do it very carefully, because you have to appreciate our lecture slide, our slides here this evening are CET accredited and they're approved by the GOC. So we can't change that content, but what we can do is change the way I talk about them, and perhaps the way in which you ask questions as well at the end. So we're going to try and emphasize everything to be relevant to the here and now and the challenges that we're facing at the moment, which I think is really what's at the front of our minds. And hopefully you'll carry this, you'll allow us to take that, that approach. Type something in the chat box to let us know that you're happy if we do that. Let us know if that's okay, and also if you'd like to, and if you can carry that approach over to the Q&A session at the end. And what we'd like you to do really is to maybe steer your questions more about how we manage dry eye now versus the clinical and the technical aspects of dry eye. Okay, so let's move on. Here we go. So our CET housekeeping, I'm going to really whiz through the next couple of slides very quickly. They're really not adding massive value, but they are important for us to tell you about. We have a 45-minute lecture. That's going to include some interactive polling slides as well. You're going to get one interactive CET point. There'll be the Q&A session at the end, and we're going to cover off 3 learning objectives. So for optometrists, that's communication, contact lenses, and ocular examination. For contact lens opticians, that's also communication, ocular examination, and again, contact lenses. And for the dispensing opticians that are listening this evening, we have contact lenses, ocular examination, and also standards of practice. So, polling slides. I've warned you that we're going to have some polling slides. This is a test slide. So this is to test whether John and I have got our technology working properly, and just to see if you're still awake and still paying attention as well. So it's a little tongue-in-cheek. Oh, I can see the polling slide has appeared. So the question is, you know, how many webinars or Zoom meetings have you attended in the last 8 weeks? And you can see I've been a little bit tongue-in-cheek here. So is it A, 1 to 99, B, 100 to 249, C, 250 to 999, or is it over 1,000? So I'm not expecting to see anything less than a C here. I think the number of virtual meetings that I've taken part in, I've lost count. I'm guessing that many of the audience are also the same. And I think we're going to soon be seeing some new sort of bloopers video compilations coming out of people from webinars and Zoom meetings who perhaps have, or maybe we've got a more serious bunch here this evening. So 1 to 99, I think, yeah, 99 is still a lot of webinars, but I'm glad to see that we've got a few people that have hit 12%, have hit over 1,000. So, okay, so that's good. But I do think we'll be seeing some new bloopers videos coming soon of people who are on Zoom meetings, but they haven't realized that they've left their camera turned on, and they think we can't see them. But please don't worry, because we can't see you at the moment. Okay, so moving on, our first genuine question. So thanks for taking part in that and indulging us with a little bit of humor there. So on a scale of 1 to 10, where 1 is not at all and 10 is very, how confident do you feel about managing contact lens related dry eye. So, you know, we've got 1 to 2 contact lens related dry eye, patient walks into test room, you're going to run a mile. 3 to 4, maybe you're just learning or you've got some basic knowledge. 5 to 6, you're pretty solid, you can handle most things. 7 to 8, you're extremely confident. And 9 to 10, you're the person that wrote the book on it. So let us know how you feel about managing contact lens related dry eye. So you can see the votes coming in. Thank you, John, for managing the poll this evening. So we'll have a look at the results in a moment. Aha, so we have a pretty confident bunch. So there is a spread across all of the groups here. We've got some real experts. That's very worrying for me as a presenter. But it'll also be good for the Q&A session because we'll have some experts to help us. 7 to 8, so is our top score, about 37%. So just over a third, a solid third of the audience this evening feeling confident. Quarter of the group are feeling pretty solid, and then we've got about 20%, 1 in 5, you know, sitting in the 1 through to 4 group there. So what we're hoping to see is that maybe we can take some of those 1s and 2s and 3s and 4s and elevate them up through the confidence scale as we talk this evening. Quick refresher on our 3 headline topics: retention, especially preventing dropout, focus on that, contact lens associated dry eye, and the management of contact lens associated dry eye, especially diagnosis, communication, and products. We see our red spot appear once again, and really I think that something that's very important to reflect on at the moment is that retention of your contact lens patients is incredibly important, because your direct debit contact lens patients are likely to be the only sort of active patients that you have at the moment. Other than essential and emergency care, this is going to be one of your core revenue streams coming into the practice. And when we think about point 3, which is the management of contact lens related dry eye, this is going to be done on a virtual or a remote basis now, which completely changes the emphasis of how we practice. Okay, so moving on to retention. Well, retention is a topic which is talked about a great deal with contact lenses. There's always a big focus on it, and you may wonder why. Well, the headline bullet point here will tell you why, and that's because the lifetime value of contact lens wearers makes them an average of 60% more profitable than spectacles only wearers. And now is a really great example of that. People can't come and make routine purchases of spectacles at the moment, and yet your direct debit patients continue to pay their monthly subscription fees. So we can actually see they're very, very valuable patients to practice. Retention is multifactorial, and it's a bit of a balancing act, actually. On one side, we've got patient motivation. So it's those lifestyle benefits and needs of contact lenses that drive that trigger for a patient to want to wear them or have the need to wear contact lenses. And on the other side of the equation, we've got preventing patient dropout, and that's the patient. Can we help the patient? As a practitioner, can we help those patients to retain the benefits of contact lens wear, all the good bits about contact lenses that enhance their lifestyles and help them to enjoy lens wear? We often talk about the leaky bucket. I think you'll be looking at this thinking, you know, when was the first time I saw the leaky bucket model? I picked this one up from the J&J website. It dates from 2016. But it is a great way, if you want to look at a whole market, it's a great way of understanding 800,000 new wearers in, 700,000 lost wearers during 2016. There's still some significant growth there, but actually you're doing quite a lot of work to put all of those new wearers in, and we've got a lot of wearers dropping out the bottom. So what can we do about this? Well, if we want to influence patient retention and we want to increase the volume of our bucket, then we've got a couple of options. We either increase the flow of new patients going into the bucket, or we stem the leak of patients flowing out. And of course, at the moment, we can't really influence the former, the first of those options. What we can do, though, is really focus on preventing the dropout at the moment, and that's where we're going to focus at the moment. So we're going to have another polling slide at this point, and I'd like you to tell us what is the main reason for losing contact lens wearers in your practice? Now, there's again, it's multifactorial. You might struggle just to pick one of these, but I would like you to try your best. Is it cost? Is it comfort? Is it vision? Is it handling? Is it going online? Or, you know, somebody that just tried it and didn't like it? So let us know what you think. So again, votes are coming in, and we should get the results of this poll soon. Okay, so I can see that the poll's disappeared. Aha, right, here we go. So cost down at 10%. Comfort is our big winner, about 40% there. So around around 40% of the audience this evening highlighting comfort as a key reason. Vision is there in some respects, and then going online. So we've got two significant, you know, again, we're ticking all the boxes there, but we've got two quite different aspects there. Comfort is something which is highlighted. We're going to look at that in more detail. And going online, so that is something that is a challenge or is a change in the way in which we do business. And actually at the moment, that could be very relevant to us working remotely and having to supply products on it. You know, we're having to be creative and establish new channels to market. So in terms of how we do interact with our patients, and whether that be from a retail basis of how we sell them a dry eye drop or how we deliver their contact lenses, we're having to come up with new channels. Seeing a lot of stuff from America at the moment, you know, curbside collections, virtual waiting rooms where patients stay in their cars before they come into the, they don't come into the waiting room, they sit in the car park outside. So going online is something that we have to think maybe as entrepreneurs or business people, how are we going to address that, or how do we embrace online buying habits or a style of online interaction with our customers? Comfort is something that sits within the consulting room with our clinician's hat on there. So retention, we're coming back to the leaky bucket. This is my model of the leaky bucket. And as you'll see, it looks a little bit different to the first one. There's a lot more going on here because there's a lot more happening face-to-face with patients in practice than there is if we just look at a big market overview. So as you can see, we've still got new wearers coming in from the left of the screen, and we've got lost wearers heading out in red on the right-hand side, but we're actually breaking it down, and we've actually got some churning arrows as well. I call this the churning bucket. So let's take a closer look, and I think when we talk through these patient groups, certainly the optoms and the CLOs out there that fit contact lenses will recognize these patients. So we've got our curious or our special occasion wearers. Something's triggered these individuals to try lenses for the first time, whether it be an advert, a friend has recommended them, they've seen a poster in the practice or read a leaflet in your waiting area. They just want to give it a go. They might not have that serious an intention, but enough motivation that it puts them in your chair and asks you to put a lens on their eye. Special occasion wearers. Weddings, special occasions, birthday parties, school balls, all of these types of things are all reasons to wear contact lenses. People will want to dress up for the big occasion. Just as they've got their special outfit, the contact lenses become part of that as well. So you might find these people their requirement or their need for contact lenses, they don't need a lot of contact lenses. They only need 1 or 2 pairs, or just 30 pairs, whatever it might be, but they still have a desire and a need to wear them. We go a little bit further down the bucket, we get to the part-time wearers and the seasonal wearers. I think I've put the red spot up here. This is very relevant. We've just seen yesterday with some of the easing of the lockdown rules, golf courses are open, sports clubs are open, we can play tennis, we can play golf, we can spend more time exercising all day long. So actually, we know that we get seasonal wearers of contact lens wearers, whether typically around sporting season, holiday season, ski season, party season. All of these will be familiar groups to you. And again, we see quite a lot of churn here because these people will need products. They need contact lenses for just certain months of the year, or only a few pairs every month for the task that they're doing. But they don't need them all the time. And then we get the full-time complex wearers. Now, these are the ones that we really like. These are essentially the people with higher prescription, complex needs, RGP wearers, Ortho-K wearers. And these are the patients who are going to be, they're going to reach for their contact lenses first before they reach for their spectacles. Okay, and so these perhaps are patients that will be set up on direct debit, paying on a regular basis because they really prioritize contact lenses. Now, something that's important to recognize with this model, especially now, because every patient is valuable to you at the moment and will be going forwards. Something that's very important to recognize is that it doesn't matter where you sit in this bucket, whether you're at the top, the middle, or the bottom. The volume of lenses that you need to purchase is not an indicator of loyalty. So you can have a patient who's incredibly loyal to your practice, but they only need one box of lenses per year, but they keep coming back to you time and time again to get them. Okay, you may have a complex wearer who thinks you're the best practitioner and they would never go anywhere else for their contact lenses. But to them, spectacles are a secondary consideration. They might purchase them online. So loyalty is not measured by the volume that they purchased from you. So you have to have a really broad spectrum of contact lens offerings, price points, ways of selling the lenses to the patients to ensure that you meet the need of every contact lens wearer that comes through your door. So let's focus on preventing dropout. Let's get back to that sort of clinical CET side of things and look more closely at what we can do in terms of those lost wearers. Well, we've got 4 headings here that we're going to look at: vision, complications, handling, comfort, and dryness. So comfort and dryness was called out by the poll as the #1 reason for people dropping out of lenses. Vision was also in there as well. So let's just take a closer look and see what we can learn about these. So vision is actually particularly relevant to new wearers. Now, this is perhaps something at the moment, it's not that relevant in the virtual world because we can't see patients for routine care and we can't over-refract them and fix their problems. But certainly for new astigmatic and presbyopic patients, vision's really important to them. So when we do get back into practice, make sure that if a patient's got cylindrical correction or they're presbyopic, make sure you're correcting those sills, reaching for toric lenses, or thinking about multifocal options, or finding what is the best presbyopic solution for that particular patient to help prevent dropout from vision. Complications. Now, these are potentially the number, from all of these 4 groups here, these will be the ones that flag themselves up to you at the moment, with hospitals perhaps with the hospital eye departments not really being open for regular things like eye casualty, and the introduction of things like Qs, MECs, ACEs, all of these different schemes. Then perhaps these are the patients that will flag up to you in the practice at the moment. So these will be people that cease because there's a complication. It may be lens related, it may be not. Okay, handling. This is key within the first 3 months. #1 reason for patients dropping out in the first 3 months. And so at the moment, these will be the last new patients you fitted during January and March. Okay, these are the ones that need a phone call right now just to check in and see how they're doing and how they're getting on. Okay, and then comfort and dryness, and you guys were spot on the money. You put it as your #1 option at 39%, and actually comfort and dryness is the #1 reason for established wearers to drop out of lens wear. Okay, so let's take a look at contact lens associated dry eye as we move on to chapter 2. So I've gone straight to TFOS Jews for the sort of headline definition of dry eye, so it would be a good starting point. I'll just read it straight from the page. So dry eye is multifactorial disease of the ocular surface, and it's characterized by a loss of homeostasis of the tear film. It's accompanied by ocular symptoms, which we see tear film instability, hyperosmolarity, ocular surface inflammation, and damage. We also get some neurosensory abnormalities as well. So we'll look a little bit more closely at that too. So I thought if we thinking that homeostasis or breakdown of homeostasis really is a key factor when it comes to dry eye itself, let's take a look at homeostasis. What does that actually look like? What does good look like? So we're going to work with a simple 3-layer structure to the tears here. We have our mucin layer that's coming from the conjunctival goblet cells. We've got our aqueous layer. We've got lipid coming from the lids, from the meibomian glands. Tonicity of around 308 milliosmoles here. Sorry, osmolarity rather, I should say. Might be a typo on my behalf. I do apologize. 308 milliosmoles. And blink rate as well. So we normally see a blinking rate of around 17 blinks per minute when we're resting, perhaps around 26 when we're in conversation. So tasks that we're doing are also going to influence that. So not only physiological elements, but also things that we're up to in the environment and the tasks we're doing as well can influence our homeostasis. So what does loss of homeostasis look like? Well, tear film instability. This is actually a list of our signs and symptoms. This is how we're going to dig into this problem and establish what's going on in practice. So tear film instability, we're going to see reduced tear breakup time or non-invasive breakup time. We see hyperosmolarity. We're going to see an increase in saltiness of the tears. And we see some ocular surface inflammation and damage. So we might see some redness, we'll see some staining. And then we might get some neurosensory factors at play here as well. So this is when I've described it as having a mismatch between the signs and the symptoms. So we may have a patient with signs, but they don't have symptoms, or we may have symptoms without the signs. So they don't always go hand in hand, and that's something to consider when you're running through your consultations. So if we take a look at how you work with the tear film in practice and how you analyze it, I'd like to find out what your primary technique for tear film analysis is. So John, if we can have the next poll, please. So hopefully we should see the voting options come up. So what's your primary technique? What's your go-to first step then? Is it qualitative slit lamp assessment? Is you check the osmolarity? Do you like to use tear breakup time as your key indicator? Do you measure the tear prism height? Take a look at volume. Is it non-invasive breakup time, or is it a combination of those factors that you use? Just waiting for that to populate. And we should see the results coming through very shortly. Combination of the above. So tear breakup time is probably the standout individual measure that many practitioners are using. So fluorescein in the tear film, counting the breakup time. Slit lamp assessment's also there. A little bit of osmolarity checking, which is interesting, but a combination above. So most of us are recognizing sort of multifactorial analysis. Okay, so let's move on. Straight, another question. So that little group that we're using osmolarity, I'd like to find out a bit more about you. So do you check osmolarity regularly as part of your tear film assessment routine? Yes, you include it as part of your regular eye examination. No, you don't do it. Or the third option, which is yes, as an additional chargeable assessment. So tell us what you do with osmolarity. And let's take a look and see. So how's that poll looking, John? So I think we could have predicted a set of results rather like this. So the majority of you not using osmolarity. And then if we take a look at the guys who are incorporating osmolarity into their routine, it's a little bit about 50-50, 12% versus 8%. So some including it as part of their regular routine. It would be great to hear from you guys that do use it, you know, the benefit and the value that you hear. Maybe you could put something down in the question box just to give us, tell us what it is about osmolarity that really works for you and how it's changed your practice. And then some people are running dedicated sort of chargeable dry eye assessments and charging independently for osmolarity checks. So contact lens associated dry eye. Let's get familiar with this. We looked at the TFOS-DEW's definition of dry eye. Now we're going to be specific at actually that dry eye which is caused by contact lens wear. So the mechanism is actually the application of the lens onto the anterior surface. So when we place the contact lens into the tear film, it separates the tear film to give us a pre and post lens tear layers. Those two layers subsequently are thinner, so we get a thinning of the pre-lens tear film, and that separation reduces the volume of aqueous layer in front of the lens, so in that pre-lens tear film. Wettability of the contact lens surface now dependent on the material chemistry. So when we take that aqueous layer and we split it and take it away from the mucin layer, the basement layer, then we're really reliant upon the chemistry and the wettability of the contact lens surface for the integrity of that pre-lens tear film. So we see instability, and then when we get breakup. Now, lots of words. Let's try and bring that to life with 3 simple pictures. Starting on the left, we've got our normal tear film. We're all familiar with this, working through the 3 layers. Nice picture in the middle. We've got a successful fit. Our contact lens now sitting there in the middle of the aqueous layer. And as you can see, it splits that aqueous layer. Some is pre and some is post. So we know a lot of contact lens manufacturers working with different additives and comfort agents, wetting agents, with their lens technology to try and improve that wettability. And this is why. And then we've got on the right-hand side here, contact lens associated dry eye, and we see what happens when that tear film breaks down, that disruption of the lipid layer. We get that evaporation of the pre-lens tear film, and then we get poor surface wettability, which then will lead to a drop in comfort as well. And what are the consequences of this to us? Well, again, I've gone back to TFOS here. And there's a grading scale here. Well, not so much of a grading scale, but there is a pathway here which takes us through the breakdown in terms of contact lens comfort caused by dry eye. So we start on the left of the screen here with the strugglers. Now this is color coded. I've put some color code on here. And one thing I'd like you to take notice of is that there's no green on here. We've got a traffic light that just goes from amber through to red. So there's none of these are acceptable. So we start with physical awareness and visual disturbance. Then we start to get reduced comfortable wearing times. Wearing time starts to reduce, temporary cessation of wear, and then ultimately, if comfort and contact lens related dry eye is too significant, we get a patient who drops out. None of these are good scenarios, especially not the last one. We'd like to do everything we can to keep as many patients with the benefits of contact lenses. And the key takeout from this slide, and as I said, we will be sharing the slides with you, so you'll have an opportunity to refer back to these later, is that the earlier you can act on this scale, the sooner you can identify the problems, then the quicker you can act and the better chance you have of success. So at the moment, with our sort of not being able to see our patients for regular checkups, it could actually be that being in practice and spending your time going through your reminders, seeing who are those contact lens patients that are due for their regular aftercares, and obviously you're not sending them a reminder at the moment, picking up the phone and doing a triage and a history and symptoms is demonstrating that you've got their best, their well-being front of mind. And that will be the opportunity that maybe you start to pick up some of these early symptoms, especially comfortable wearing time. We'll come back to how we talk about and communicate during our virtual consultations. So signs and symptoms. Now, I introduced another bit of color coding here because if we look at the top here, which is our signs, poor surface wetting, low pre-lens tear film breakup time and so forth, redness, staining, lid wiper epitheliopathy, these are our signs. And these are off limits at the moment. We can't go to our slit lamp and look for these. So we need to focus our attention on our symptoms and our history and symptoms to make sure that they're as effective as possible. So reduced end of day comfort, visual disturbance, foreign body sensation, and typically symptoms are worse at the end of the day. So that is a key trait of contact lens related dry eye. So at the moment, we've got our red dot here to tell us that we'll be focusing more on our history and symptoms or symptoms than we will be on the signs. So another question for you. What's the most frequently reported symptom of contact lens associated dry eye that you encountered during your aftercare? So we've called out 3 here. Option 1, blurred vision, 2 is foreign body sensation, and 3 is reduced end of day comfort. Okay, taking a quick swig of water there. And John, how is that poll looking now? We should have some votes coming in now. Reduced end of day comfort. So a telltale sign there, and something which is good news for us, because working with our virtual remote triage and consultations, that's something that we can find out about with good questioning and good communication. Okay, so let's take a look at how we manage contact lens associated dry eye. Another question for you. So I'd like to know that when you're managing contact lens associated dry eye, what do you typically do first? Do you have a go-to strategy that you use for managing this? Do you change the lens material, change the modality, introduce eye drops? Do you introduce warm meibomian gland compresses, so you take a therapeutic approach, or do you cease lens wear? Again, it might be a challenge to pull out just one of these. I'm sure most of you out there, because we had a lot of high scorers in the confidence ranking, probably most of you are using multifactorial approach to managing this, but which one would you call out first? So let's take a look. Introduce eye drops is a significant option there. Change lens material coming in second at 25%. Modality is considered as well. And then, so yeah, again, we're touching everything. A few people would cease lens wear. So we're really hitting each box there. So they're all relevant, but we're seeing that most of you, a significant proportion of you, would be reaching for some kind of dry eye drop. So communication. Actually, just one second. I may have skipped a slide there. No, I didn't. Okay, so history and symptoms. Again, I've shaded all of these in blue because I think communication at the moment is absolutely key to us. It's something that's always fascinated me in terms of how a practitioner communicates with a patient to get the most out of the consultation. But now we're having to do it remotely. Now we're having to do it over the telephone or on Fleming or any of the other Zoom health platforms that you might be using. So it's important to have great communication techniques because we know that symptoms, especially end-of-day comfort, is a key identifier of contact lens associated dry eye. Subjective scoring of comfort. So I said we'd come back to this. So it's very important, rather than just we can think we're great using open questions. How comfortable are your lenses? However, what we need to establish is how do those lenses feel on application? How do they feel in the middle of the day? How do they feel at the end of the day? And you can really get into this and start to bring these questions to life for patients. If you understand what their working day looks like and you can paint a mental picture of their tube trip to work or their cycle to work, what their office is like, how many hours they spend there, how much screen time, then you can ask and introduce those comfort grading questions at the different various stages of the day to see how their comfort drops as the day goes through. Reading and screen time can lead to reduced blink rates. So we saw earlier that blink rates typically around 17 per minute when resting. Well, actually, if we're reading, blinking rate can drop to as low as about 4 to 5 blinks per minute. So very significant reduction there, which leads to increased evaporation. It's really important for us to differentiate contact lens associated dry eye from dry eye disease. If we've got a patient who's got dry eye disease or an underlying pathology, then we need to manage that first and manage their expectations. And lifestyle questionnaires, again, very helpful to really paint that picture of your patient's working day. That brings us on to this, the Dry Eye Questionnaire 5, the DEQ5. Now, I've put a picture of the Avizor version up here. So I want to make sure I get, because there's different information on this slide here. So simple 5-question questionnaire, looking at the frequency of the symptoms, the severity of the symptoms, and what's the impact of the symptoms on the wearer. Now, so I'm referencing the DEQ5 from Indiana University here when I talk about the scoring here. So applying a score based upon the answers to the questions, we get a score of greater than 6 would indicate dry eye. A score of greater than 12 may indicate further testing to rule out more significant types of dry eye. But if we take a look at the Avizor, questionnaire here, there's some pretty neat work here looking at a grading, and it's rather hidden, but you'll see this. You can get this, download it from Avizor and get copies of this to use in practice. But a grading scale being applied here. Greater than 8 would indicate dry eye, and they've applied it to their products as well, which is quite neat to help you with your prescribing. But I think the key thing here is that if you introduce a questionnaire into your history and symptoms, especially now that we're working virtually, whether it be remotely by video or over the telephone, it's going to help to bring a level of consistency to your diagnosis and to your triage. Just as grading scales help you when it comes to grading signs when you're in practice. So I think these are absolutely great tools to help you with this identifying your dry eye wearers. Signs, again, we will perhaps go through this at quite a rate because this is something which is off limits at the moment. So we know that our slit lamp is likely to be the primary instrument. We're going to be using stains such as lissamine green and fluorescein. We can see smile staining over here. I don't know whether you can see my cursor floating around. We've got some conjunctival edge staining here, nice image from Efron. We'll need to ensure we've got our Ratten filters and our cobalt blue light sources to get the best images. And grading as well. And perhaps if we are any younger practitioners or less experienced practitioners, I say this not disrespectfully at all, as somebody that teaches optometrists to fit contact lenses at Cardiff, something that we try to instill from an early stage is being consistent. And so if you've got a scale that you like to use or prefer to use, stick with that scale. That's really important, especially if you're managing a patient long term. If you're reaching for CCLRU 1 week, Efron the next week, you do need to obviously keep using the same scale. Okay. Again, further diagnostic tests. Lissamine green is going to show us, going to really help us look at the lid wiper. And lid wiper epitheliopathy is one of those ones where you maybe have a patient with symptoms, but you don't see any signs when you look at the front surface of the eye. But as soon as you roll the lids out and invert the lids, you can see that Mark's line has broken down, and we see that the broadening of Mark's line there, and it indicates lid wiper epitheliopathy, which of course does respond really nicely to the use of lubricants and wetting agents to do that. Placido disc, it'd be really interesting to know if any of you still use a Placido disc. I've got a really neat small one which goes on the handle of my RET, so it's powered off the RET handle. And it's really helpful for me as a locum just to be checking breakup times. I like to do that as least invasive as possible. And of course, slit lamp reflex as well can just be an indicator as to how well that front surface is wetting. You know, this really diffuse image on the front surface of the lens here, it really indicates the tear film's broken down significantly. So, osmolarity, we touched upon this. So we do have some members of the audience that are using osmolarity on a regular basis. We've had the Tearscope is something which is less commonly seen these days, but some of them may still be out there. However, Tearlab and also the iPen, which is a really neat little remote solution there for taking tonicity, for osmolarity rather, is these are great ways to establish sort of osmolarity as a gold standard and can be introduced into practice. We've seen some of you already doing it, some of you are charging for it, some of you just incorporating into your regular assessment. And something that might be of interest now is that potentially these tear assessments can be done slightly more remotely with less close facial proximity to the patient, and that could be really beneficial to us in the way we're practicing in a couple of months' time when we go back to regular work. Management. So things that we can do, as I've already mentioned, differential diagnosis is very important to identify underlying problems. If we do have a patient with dry eye, it's very important that we identify them and we don't, and we manage the underlying pathology and the underlying cause, and perhaps have to manage those patients' expectations in what level of comfort they're going to achieve. Lifestyle, very important. And again, now with life in lockdown, we're seeing screen usage increase. Lifestyle is not normal at the moment, and therefore potentially some of your existing wearers are going to be more likely to be suffering from dryness related to screen use and reduced blink rate. Lens material, we can't do anything about that at the moment. Tear film stability, we can't check. And then finally, written guidance to help improve compliance is very important. So that's something that you can provide to ensure that your recommendations are followed through more consistently by your patients. Lens material, I'm going to skip through this quite quickly because it is an aspect of management that we can't effect at the moment. Changing the material, changing the modality. If it's an RGP lens, we may change the fit to improve or to reduce the impact on the tear film. I've mentioned this already, that comfort enhancers, different products, things like PC technology from CubaVision or hydroxypropyl methyl cellulose as blister additives. Every manufacturer's got a different terminology for this. So you might have to sit down with your lens reps and just scratch the surface beneath the glossy marketing to find out what actually is it that makes their product more wettable. Consider changing the solutions as well. So the majority of the solutions that we have available to us at the moment are based around polyhexanide. So we have a kind of less choice than we used to have on lens disinfectants and preservatives. So again, that's an area that you can investigate and look for products that have really sort of interesting or innovative comfort agents incorporated into their formulations. Modality, perhaps replacing the lens more frequently, will help for those patients who suffer with high levels of deposition. Manage their wearing schedule, but if you do have to reduce lens wear, consider the impact it might have on that patient's lifestyle, and are you still going to have contact lens wear that meets their needs? And also consider the impact of refitting. Is changing the material the right thing to do? The cost of the impact of the chair time and the cost of the patient in terms of repeat visits. Perhaps some of you are already one step ahead there because we had using wetting drops or using drops as the number one option in terms of management. And possibly if you've got a patient that's wearing a great lens already, it might not be the lens material. So always think about that too. The tear film, and really the thinking behind this is that regardless as to whether the patient has a healthy tear film or not, any steps that we can take to improve the quality of the tears gives that lens a better chance of success. So it could be warm compresses with meibomian gland therapy, 10 to 15 minutes at about 40 degrees is the optimum temperature. Blinking exercises. And some practitioners really get good results with blinking exercises. I've never been able to really train them into my patients very well. I need some development on my communication there. And then we've got the wetting drops as well. So what can we do to improve the quality of those tears? What can we do to help lubricate and wet the surface of the lens? And how can we influence tonicity? So let's take a closer look at the products. I'm a little bit mindful. You probably hear me speaking a little more quickly, that I'm eating into the Q&A time. So we've just got a handful of slides to go. So what is it that we actually want from contact lens dry eye products? Well, we'd like to increase the viscosity of the tears. So we'd like to have some additional lubrication over the surface of the lens. So we want to lubricate. We'd like to influence the tonicity as well. So we'd like to address hyperosmolarity. We'd also like to soothe any discomfort there might be from the dryness, and if there's any staining there, we'd also like to help promote the healing of the ocular surface. So we are going to ask quite a lot of our products. They really need to tick a lot of boxes to be successful. What type of ingredients are we going to find in there? Well, we're going to find humectants, electrolytes, and demulcents. So if we think about humectants, these are really water-loving compounds. So they help to retain water, and they're quite resistant to dehydration. That's a good attribute to have for a product which is going to be used within the tear film. And demulcents as well. So these help to form layers, smooth layers over mucous membranes. So they're absolutely brilliant for going in on that basement, that mucin layer against the front surface of the cornea, helping to fill in any gaps and potentially help to promote epithelial healing as well. And also we've got electrolytes, which will help maintain tonicity too. If we look a little bit closer at those and see what are the typical ingredients, so what would we look out for when we take a look at the packaging of the products we're selecting? Well, glycerin is a very effective demulcent. It has the benefit of not only lubricating, but it's a humectant as well. So it's kind of ticking a lot of boxes. It's not only shoring up the mucin layer, but it's actually helping to retain moisture as well and lubricate. Povidone is something sometimes referred to as PVP, and that's going to really help with the lipid layer. So that's going to help shore up that front surface to help resist dehydration. And sodium hyaluronate. Now, this is becoming the king of all dry eye ingredients. Everybody's seen it. This is getting into makeup as well. So this is a humectant. So again, it loves water. It holds onto it. So we don't need it to plump up our lips or our eyelids, but what we do need it to do is to try and hold on to that water content in the tear film and improve wetting. So my own market research here, and this involved pre-lockdown, I hasten to add, having a look at lots of opticians' accessories displays and looking at what are some of the really popular products, what are some of the products that we're going to be reaching for. So the big three I found were really the Tealoz Duo, the Hycosan Extra, and also the Lacrofresh OcuDry there in the 0.3. And some have got more pictures than others here. So something else which is very important well, I think is important from a managing dry eye perspective is some of these products that come in multiple formats. So the Tealoz and the Lacrofresh coming here with not only unit dose but also bottles as well, multi-dose and unit dose. The Hycosan famous for its sort of rather clunky clicker that you squeeze and click there. But if you have a patient that prefers to just break off a couple of vials here, pop those in a pocket or keep them in the drawer at work, then you've got another opportunity, something that can just help you with compliance. So it's also important to understand what your patient prefers in terms of how they use these dry eye products. A bit of a shootout here, a bit of a comparison to see how they compare. So I've looked at the amount of hyaluronic acid that's in each product, and you see there's a bit of variation there, 0.2 for Hycosan, 0.3 for the Lacrofresh. So what's interesting is if you then take a look at the viscosity, and you can see that the viscosity, that perhaps the absolute level of hyaluronic acid is not exclusively responsible for how viscous the product is. So we can see Hycosan is pretty close in terms of viscosity to Lacrofresh, even though it's only got 2/3 of the concentration. So it tells us that other factors are at play when it comes to the formulation. If we take a look across at osmolarity, we can see the Lacrofresh and the Tealoz are really quite significantly hypertonic there. And we also can see there's some additional benefits to the product with glycerin, povidone, the Tealoz as well, and the inclusion of electrolytes as well. So each product is not like for like. So we tend to look at this headline value for hyaluronic acid, but there's a lot of other stuff that's going on in the formulation as well. And so finally, just a little summary table here, looking at those big three, just to see how they stack up in terms of hitting those objectives of high viscosity, low osmolarity, and also very importantly being preservative free as well. Okay, so here's our summary. This is the slide we've been waiting for. We've got still got some time left for questions. I think it's handling, prescription, and comfort. They're all factors in patient dropout, but comfort is the #1 reason for established wearers. Contact lens associated dry eye is multifactorial. Open questions, dry eye questionnaires are really going to help you with these virtual history and symptoms and triages to understand your patient's underlying problems. Currently, the use of remote triage is going to reduce our scope for managing contact lens associated dry eye. It rules out lens material and some of the therapeutic approaches because we can't see our patient, but we can still look at using drops. We want those drops to be preservative free, hypertonic and viscous, and it's very important at the moment to maintain contact with your patients at this time to help influence retention as well. These are our references, which will be available for you to read through when you get copies of the slide deck. And finally, on a scale of 1 to 10, this looks like a familiar question. I'd like us to return and have a look at the confidence scale here. So again, John, if we could bring up the final, voting slide, and then we can just poll and see how confident we feel. So we had some A's and B's last time. John, do I still have you there?
Yes, I'm still here, Mark. I must admit, I do apologise. I have omitted to add this question. I don't know why. I do apologise. Maybe what we can say is, if people would like to put into the chat what they think, and we can have a quick look. I do apologise, Mark. I had 7 questions. I must have missed this one.
No problem. Well, I apologise for running over as well. So let's skip on. Let's go to our Q&A. So again, I'd like to thank SiteCare and Avisor for facilitating this. I'd like to apologise for running over and compressing the Q&A time. Gary Daniels' details are there, so I'm going to skip and avoid sort of product-related questions. If anybody wants any further insight into Avisor products, they can contact Gary through there. And I'm just going to hope I can do this, which is to open up the Q&A section, which is okay. Actually, what looks like just 3 questions. So this could be quite quick and quite simple. So let's have a look. So we've got one question, which is cost being probably incorporated with going online. So thank you, Nicola Hall, for that question in terms of looking at online retention. And so why is it a patient may head offline? That was our second most popular reason for losing patients to the practice. And again, I think there are different sides to that. Costs, some patients will be very driven by cost. If anybody here is a member of Costco, if anyone has a Costco card, then you'll know that cost can motivate some people. The size of the discount, big ticket discounts, sometimes it doesn't even matter what the actual cost of the item is. It's the deal or the bargain or the price per unit that really motivates some people. And there's not a great deal you can do with those people, but you do need to take the opportunity to demonstrate the value that you bring. So being able to demonstrate why you're at one price level and why the internet is at a different price level, that is an important thing to do. And then perhaps by the time that patient then can be demonstrated that by the time they've purchased online at a perceived lower price point, that by the time they've purchased their care, their customer service, the experience and the skill that you bring, then they recognize that actually the price is quite similar. The prices will be much closer. And so it's very important to emphasize the convenience, the care, and the customer service that you bring, and then it all has a price as well. We've got a question from Nick. As dry eye is an inflammatory condition and contact lenses cause inflammation, why was testing for this not discussed? Not sure I understand exactly what you're getting at there, Nick. So we've been looking at contact lens, really quite specifically at contact lens associated dry eye and isolating that mechanism there rather so than inflammation. I mean, inflammation be a secondary. We've looked at inflammation as a secondary sign of the dryness that's caused by the disruption of the tear film when the contact lens is applied there. So happy to pick that up offline a little bit later if you want to expand upon that. How much does body hydration play a part? So patient physiology, and this is going to fall really when we have a look at if we take a look at diet and nutrition, not a specialist area of mine myself, but if we take a look at the overall the lifestyle of the patient, not just the environment or the working conditions that they're exposed to on a daily basis, hydration and diet is also going to play a part there as well. So these are all elements that you can incorporate into your history and symptoms. I'm looking at my timer. I'm seeing that it's 2 minutes past. I know that we kicked off at 3 minutes past 6, so we're at 59 minutes now. John, I think that is...
Mark, there's another question. If you look further down the list, Kazim Azaria is asking, during lockdown stroke virtual triage, do you have to go to drop for patients?
Do you have to go to drop?
Question, if you just scroll down.
Yeah, no, that's a good question. I'm glad that we've had a question. I'm glad I've seen the guitar question as well. I'll probably talk for another hour about guitars. So I think, do you have to go to drops? Um, at the moment, that is your virtual triage is really going to guide you in terms of what you feel is going to be the best management strategy for that patient. We looked at those reasons for patients dropping out. One of them was complications. And therefore, if you have a well-structured triage and a well-structured consultation, if you're finding that you're highlighting symptoms of pain or symptoms that are associated with microbial keratitis, infection, injury, then prescribing a drop is not the right way to go. That particular patient is probably going to fall into the emergency or essential category, and they're going to demand a face-to-face consultation. And depending on how you're currently running your practice and at the moment, if you are actually seeing patients face-to-face, then you're going to want to pull that patient in to get them on the slit lamp and to examine them, obviously in using the appropriate PPE and safely. If you haven't got that capacity at the moment to practice, but you're still just operating your premises virtually, if you've got your phone lines and access to your records, but you're not seeing patients, then you know you're going to need to refer that patient. You're going to need to refer that patient either to the local A&E or iCasualty pathway, or to another practice which may be open that's part of Q's or maybe has a MEX service. So that decision is going to be driven by the outcome of your history and symptoms, which it should be every time. And so I hope that has covered that one off. The guitars are a Fender Telecaster 72 Custom, Stratocaster Wayne Craig.
Above the guitars, Mark, from Jane. How does vitamin A help dry eye?
How does vitamin A? Again, nutrition, not my particular strong point, but I can certainly do some research on that, and I can come back to Jay. On that and pick that up after.
A couple more there as well. Do you have time for those, or would you like to pick those up?
I'm really driven by you, John, in terms of time.
Yeah, I'm fine if you've got the time, Mark. It'd be lovely to cover the questions.
I'm going to be very honest. I think as probably most people, if anybody has heard me lecture before, I'm probably slightly more technical than say diet and nutrition. Not strong points for me. And we're getting some nutrition questions here. So we've got omega-3s there again. We can certainly help answer that offline at a later point. What advice on supply of contact lenses without checkups at the moment? So yeah, this is a really good question. This is a really good question when it comes to where we are at the moment. I think we need to look at the GOC statement that was issued early on in the crisis, which recognized that primary healthcare practitioners would need to work in different ways. And so there has been a relaxation around the supply of optical appliances, including contact lenses. And we are able to, whereas we'll have all been very strict in terms of ensuring that specifications and eye examinations are up to date and within date before we supply. There's a realization and we recognize that at the moment we can't see patients for routine care, and therefore we have that subsequently a sensible approach from the GOC, and I think it's across most healthcare regulators that as long as we are acting in the best interest of the patients, that it is okay for that supply to go on. I certainly know in the practices that I'm working in association with, then we are those practices that have perhaps been more proactive have been commercially more successful during this time. So those patients who have been perhaps going through the reminders that they would have sent out, but rather than sending the reminder, have been taking the opportunity to check in with the patient and to ring them up and to run through a remote triage at that point and just to check in. And it's a great opportunity just to maintain that relationship with your patients. That is the opportunity then where you're hoping that triage is going to highlight if that patient has an issue, and then you're going to respond appropriately from the result of that triage. So at the moment we have that flexibility to continue to supply without regular checkups. But I personally think it would be prudent, and I think it would be good business and great patient care and great customer service to pick up the phone and talk to those customers. We're probably finding that somewhere around 1 to 2 of every 20 patients, you're going to find something that you need to act upon, and you're going to need to address either by inviting them into the practice or referring if required. Okay. So I think, John, we will call it a day there. We thank everybody for their patience, and I do apologise once again for running over.
No, not at all, Mark. And I'm sure everybody wants to join me in thanking you so much for a wonderful webinar, wonderful presentation, and with CET to boot. So it's been a really productive and educational evening, Mark. Mark, I'm sure would take any questions that maybe weren't able to be answered tonight if you'd like to contact him. And of course, you've got Gary Daniels' contact details on the screen should you want to find out any more about Avizor Eye Care Solutions. I'd just like to also thank Gary and Avizor for facilitating tonight's webinar in partnership with Mark. So thank you again, Mark. Thank you to everybody for attending. Enjoy the rest of your evening, and look forward to seeing you all again soon. Thank you and good night, Mark.
Thank you, John. Thanks, everybody.
Bye-bye. Bye-bye.